Welcome to Care Transitions Today, Case by Case, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we take a fresh look at the real-world challenges of case management related to care coordination, patient transitions, utilization management, and complex discharge planning. Today, we are joined by Dr. Rebecca Severe and Dr. Sweta Singh. Dr. Rebecca Severe is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Whether you're a physician, case manager, or leader in case management, this season provides valuable insights to navigate complex patient transitions. This is Care Transitions Today, Case by Case. Let's begin the discussion with our first case.
Welcome. My name is Dr. Ariana Peters. I am the Association of Physician Leadership and Care Management current board president. And today we're going to talk a little bit about the overlap of utilization management into patient care in the aspect of having potential difficult discussions or challenging discussions where there might be somewhat of a lack of understanding of Medicare and CMS guidelines and rules with regard to patients' admission status, with regard to the number of midnights that patients are spending in the hospital, and how to navigate that. And I want to open by saying that I don't have all the answers to this. This is definitely a dialogue, so I'm very grateful for Dr. Severe and Dr. Singh to provide their thoughts as well. This was a rather interesting case that just happened when I was rounding as a hospitalist within this past week, and I thought it would be great for us to have a dialogue about. So this patient has a Medicare Advantage plan and is from out of state and winters here in Arizona, where I currently am, and presented with complaints of weakness and kind of vague complaints. Weakness, chills, feeling unwell, no real pain anywhere. And she also had a history of a renal transplant. I think it was like 20 some years ago. So it was a kidney that was doing very, very well, and presented to our hospital with those presenting symptoms. And because her symptoms were a little more vague, she had additional imaging that was done to sort of work things up, which included a CT of the abdomen and pelvis, which found some irritation. I think it was related with cystitis, potentially with her transplanted kidney, but it also incidentally found cholelithiasis and the potential for choledocholithiasis/cholangitis. But she was totally asymptomatic from a traditional standpoint, if you will. No pain, no postprandial symptoms, nothing that would make you think this was her gallbladder. But she did have a UA that was indicative of an infection. So we placed the patient on IV antibiotics, got cultures, and then started having a discussion about what we would do about the gallbladder. And part of that workup included getting an ultrasound, and the ultrasound did confirm that there were gallstones present, and there was concern that the stones were at risk of migrating up towards her pancreatic duct. And so we involved general surgery to make a determination as to when or if her gallbladder would need to come out, and if it was indeed the source of her symptoms, especially in the setting of a transplant patient. I don't know if Dr. Severe or Dr. Singh have any questions at this point of just kind of the patient's presentation. I'll pause there.
I mean, so far, it's very similar to a lot of admissions we get, these elderly patients coming in with vague symptoms, potential for something bad, but you don't know which way they're going. So I think when I get these cases as a physician advisor, I can go either way on what I recommend for a status. It just really depends on how much objective information I have. I don't know, this one to me, I would probably favor inpatient just given the transplant history and the fact you're working up a couple diagnoses. But I guess that's kind of what I'm thinking so far. I don't know, Sweta, if you've got some other PA or hospitalist thoughts on this one.
I agree with you, Rebecca. I think it's a little bit hard to know which direction are we going, and especially when we have an ongoing workup and things may turn out to be fine, patient feeling better and can leave pretty soon versus, hey, still things are unknown, but potential for high risk, where there can be risk for morbidity and mortality, and thus need this workup to be continued in the hospital. And that's why I need continued care. So a little bit, I would like to know, again, is the payer one that follows a 2 midnight rule, or is it more of like a Medicare or Medicare Advantage plan, or is it one of those commercial payers where they'd rather go by 48-hour rule to see what happens beyond 48 hours and if there is continued care needs. And then based on that, we'll make a determination if we'd convert from obs to inpatient or continue for another night on observation to see what happens.
Yes. Yeah. So to answer your question, Sweta, this patient has a Medicare Advantage plan, and our hospital is out of network with Medicare Advantage plans. And so we initiated discussions with the patient because she was out of network, and, to allow her to make an educated decision and an informed decision on whether she should be transferred to an in-network facility or not. One of her main concerns was that she wanted to be at a facility where there was access to transplant nephrology, which some of the surrounding facilities around us either did not have beds that did have transplant neph, or they didn't have that service line available. And so she made the decision to stay at our hospital because she felt more comfortable being in a facility where we did have access to transplant nephrology. I believe we did, for a very short period of time, start her out as observation, but then we did convert her to inpatient level of care before midnight number 1. And the reason was because of what both of you have referenced, which is this is a transplant patient. We did have her on IV antibiotics. We were awaiting cultures. She's therefore immunosuppressed and did have sources of infection, right? We knew that the urine was a source. At least preliminarily, it looked infected. It looked like she had cystitis, and also that the gallbladder was a potential source as well. So we had not one, but 2 sources of infection. So we made the decision to convert her to inpatient status. This coincidentally fell over a holiday weekend. I think it was President's Day weekend. So notifying the payer, also there was a little bit of delay there because they were closed over the holiday weekend. And then we did ultimately receive an inpatient denial for this patient, I think likely because the admitting diagnosis said something like weakness and chills, right? Like that's more likely to be observation level of care. I don't know if the two of you can comment on seeing that kind of, like what you do in those circumstances.
I'm actually curious and want to make sure the denial was on the medical grounds and not the technical ground, saying it's an out of network. Because medically, like you said, initially sometimes weakness or chills will not get us far, but those we can discuss with the payer, hey, there is medical necessity. And especially in this case, and I totally agree with the patient, I would not just talk about patient being uncomfortable with the transfer, but also medically, patient is right. There is a potential risk, not just of UTI, and if patient's having chills, I often say that means, and in a transplanted patient, because I take care of a lot of renal transplant patients, they get pyelonephritis pretty quickly, pretty bad. And if you have to hold their immunosuppression for 48 hours or while on antibiotics, and this is something that decision has to be coming from transplant nephrologist. This is not something that we want regular nephrologist or bedside provider be making just to make sure. Again, I don't know how far out was the transplant because those things, there's so many factors that go into that decision making. And so it makes it medically necessary that the patient needed that level of care that's not feasible within network or is not available because there are no beds. And I would document attempt to reach out to these in-network hospitals which have that access, have that transplant, but they do not have a bed available. So I would also consider it an EMTALA violation if we try transfer unsafely a patient who needs that care just because they're out of network. So I would keep those things in mind too.
Yes. Yeah. And I think, sorry, Becca, go ahead.
I was going to say, no, I think the way you manage this really depends on what type of denial you have, because I think out-of-network denials are special, and they are going to vary widely depending on which payer you deal with. I mean, if you truly are a medical necessity denial for inpatient and they're not caught up on the out-of-network, then this could be fairly easy, I think, to go your normal approach of a peer-to-peer, get it overturned. But if it's out-of-network, you really need to do other things. And I like where Sweta was going, because I find that if you're going to make the case, whether it's concurrently, some of these you have to do post-claim with a written appeal, you need all the evidence that you can gather about why it was medically necessary that this patient was in your facility. Because I've had them pick apart, how did they get to the hospital? Oh, they came by private vehicle. It doesn't matter. They were in septic shock by the time they got by the private vehicle to your ER. It's how they got there. So it really, like, you have to make the case for medical necessity. We actually have a template we use for documenting our attempts to contact the in-network payers, our attempts to talk to the payer and have the conversation. I think if you can ever talk to the payer, UM or case manager about this, that's really the best. You really plead your case and make the story around why your facility is appropriate and why it's urgent. So I guess those are my initial thoughts. So I'd like to love to hear how this one played out for you.
Agreed. Right. I know it's kind of this was an evolving story for sure. So, and I think that was one of the reasons why I thought this case was great to discuss, not only from the out of network perspective. The denial was actually an inpatient level of care denial. The payer was saying that the patient should have been under observation level of care. So it was not an out of network denial. It was a status denial. However, in layman's terms, if you will, when the patient hears this, there was a lot of discussion with this particular patient and her family with regard to whether her insurance would cover her admission. And I think some of her confusion stemmed from what she actually did, which was to contact her insurance. And when you don't know the buzzwords and you don't know how to describe your situation, and you may or may not be speaking to an individual that can answer those questions, it can cause more angst than benefit, I think, because the patient does not understand the correct terminology to use when asking the questions. It's asking the right questions and knowing the right terminology. And so I think there was a level of confusion with the patient because she was out of network, but also I don't think that she understood the difference between inpatient and observation or outpatient level of care and what the denial actually was. And despite repeated attempts to explain this to her and her family, I think she kept thinking, but I have insurance. They told me I have insurance. And so it became a challenge, an emotionally charged situation just because of angst with the patient and her family. And then on top of that, she was facing potential surgery. And so then the cost became a discussion. How much will this cost me if I'm out of network, if I don't have any coverage? And it just sort of snowballed on her end from there. And trying to piece apart and help her and her family understand what was happening here. No, you came through the ED. It should be covered. Things should be okay, but you might have a higher out-of-pocket cost. Those discussions are never easy to have with patients. They're sick and they're in the hospital, and the last thing they want to be thinking about is the bill that they're going to get when they're better, right? And when they are discharged from the hospital. So navigating that discussion became a large part of what we ended up discussing with her and her family. I don't know what other thoughts you guys have.
I think that the thing you need to know when you're dealing with an out-of-network is, does that patient have out-of-network benefits? We do have one of our common out-of-network Medicare Advantage plans that we see within our organization. They have out-of-network benefits. So it's fine. I think to the patient, there's minimal impact, maybe a slightly higher copay, but very minimal impact. We don't worry about it. But some of the plans we deal with, there really is no coverage. And it can be very, very hard to make the case that your facility was the only one that could serve. We're in a lot of my hospitals are in a metro area, and we've got multiple academic medical centers within a short distance that they technically could go to by ambulance at least. So unless they're like so unstable, you can't even put them in an ambulance, or the services are simply not available and your hospital is the only one that has it, you really do have to start having a conversation with the patient and family and say, hey, you are out of network. That means that this will likely be patient responsibility, especially if we've stabilized you. And then you do have to work on the transfer. Otherwise, it probably won't be covered. You never know. These are tricky. You really have to be able to talk to someone at the pair to understand your situations. I don't know, Sweta, anything else you would think about doing right now with this?
No, I think you rightly said it, again, depends on what their coverage, even out of network, looks like. And two, just making them aware, but at the same time, like you said, Ariana, awareness does not necessarily mean understanding. And how much are they actually grasping? And if that's adding more to the confusion. And sometimes it's helpful to have them, hey, why don't you talk to your payer or customer service, and they can help explain while our team also tries to explain things.
Right.
And try find out more information.
Right.
Sometimes it's easy to do a 3-way call between the payer, customer service person, the patient, and someone from our team. So we all are listening and talking and hearing the same thing, rather than A is giving B information, B is trying to say that information to C.
Well, it's funny you mentioned that, because that was that's actually what transpired, and I think a day or so later. So in the interim time, as the story evolves, the patient developed a bacteremia, and the plot twist even further with that was that it was the same organism that was growing in her urine. Same sensitivities, same organism, same everything. So then it became, well, do we even really need to take the gallbladder out? Because if we've identified that the more likely source is the urine, then why do we need to have her undergo surgery? Then that circled back to, she's out of network. What's going to be the cost? She's saying that her insurance doesn't give her any coverage. So it was a lot of this back and forth about, do I need surgery? Do I not need surgery? What do I do? Do I get the gallbladder out? Do I not? So there were a lot of discussions, and it really shouldn't matter what your insurance will or will not cover in the moment when you're trying to decide what's the best thing for my medical care. And so, but it did have an influence on whether this patient was going to proceed with surgery or not. And we discussed whether she should go back to where she normally lives and try to pursue getting in to see a primary care and then getting in to see a surgeon and all of that. But ultimately the decision was made to proceed with surgery because general surgery felt that the gallstones, at least one of them, was at risk of migrating towards her pancreatic duct sooner rather than later. And in a transplant patient, that's not a great clinical scenario to have. And by this time she had a couple of days of IV antibiotics and she was quite stable. No fevers, white count had come down. She was doing much better. So then the thought occurred to me, which brings me back to what Sweta was saying, which is, what if this patient had been cared for by any one of our hospitalists who certainly could have handled the discussions and certainly could have handled her care? It just so happens that I am a physician advisor and that I do have that background knowledge. And what if she had been cared for by one of our providers that doesn't know all of that? Which brings me to what happened once the weekend cleared and we were up towards a weekday. I received a call from one of the case managers on the floor saying that the patient was on the phone at that moment with her payer to talk about her benefits. And the patient was quite upset because what she heard from the payer, which was not really actually the case, but what she heard the payer say and interpreted it as is that she didn't have any benefits at all. So then we went all the way back again to square one with the panic that ensued. And now the patient was literally about to go to surgery. Literally, they were coming to get her to take her to surgery. So she's getting upset. She's emotional. She's crying. And they called me to let me know that the patient was on the phone with a representative from the payer. And I knew enough as a physician advisor, having done a lot of peer-to-peers, I knew enough to drop what I was doing and go down to that room and speak directly with the representative from the insurance company on the phone. When you have a human being, a live person on the other end of the phone, you have to take advantage of that. And honestly, I'm not sure that my other colleagues who don't regularly do this work would have known that that would have been beneficial. And they would have let care management have that discussion because they're the subject matter experts. Why wouldn't they? There's no reason for them to drop everything, but I knew that there was. And so I did. I stopped what I was doing and went downstairs and went into the patient's room and was able to speak on the phone directly with the payer representative. And the payer representative was trying to get coding information from the patient. It was clearly there was confusion, but I knew to redirect the discussion, ask the representative, tell me what you need and give me a phone number and a name where we can get that information to you. And then after that, I gave that information to our denials team and it went where it needed to go. And we were able to overturn the denial after that. So, and this is all before the patient went to surgery. So that was the outcome of overturning the denial. And what we heard on the back end was that they were using a different DRG or something. I don't know exactly what the additional information was, but that's what I was told. And so it all has a happy ending. The patient went to surgery and cleared her bacteremia and was able to be discharged, and the denial was overturned. But that is the end result of what happened. But it did spark a lot of thought in my mind of what if it hadn't have been one of our hospitalists who also happens to be a physician advisor who knows what to do.
I do think that that's the value of having site PAs. I don't know that you have to physically be there necessarily, but I think you develop the relationship. So I know our physician advisor team, when clinicians get something that's insurance, they'll be like, help me. They know where to go, and they know that they don't know. And they'll turn to care management as well, but they do have a good relationship with our physician advisor team. And oftentimes they will loop them in and kind of know that they don't know. So I think that is the value that a physician advisor program can bring to an organization and hospital.
That was probably the one of the best parts about it, is that I knew who to call. I think that's a big leadership lesson in general, is a lot of times as a leader, you may not know the answers to the questions, but you tend to know who might be able to help you. And I knew exactly who to call to get that information to, so that we could then get the paperwork processed and do what we needed to do to overturn the denial. So it wasn't the fact that I did it. It was the fact that I just knew where to get it to. Having those connections and those relations, as you said, Rebecca, is so important. I mean, we work with our denials team so closely that all I had to do was call her on the phone and we got it taken care of.
Yeah, I think, Ariana, you raised a very good point as a leader, having that connections and knowing who to call, or having that networking is very important. So you have important people on the speed dial. I think it also, another good learning lesson here is, like you rightly said, not all bedside providers would know that, who to call or what should the process be. And so it's a good idea to have an escalation pathways lined up, or clear instructions of, hey, in case of doubt, this related, this is your person point of contact, and they can help further
in case of emergency.
And they can help navigate through the system or through the whichever channels we need to go to. But not having a clear escalation pathways leads to more confusion, anxiety, and inefficiencies. So having a lot of these things streamlined or clarified beforehand helps reduce any of these difficult situations in future state, and helps not only move the progression of care, but also patients feel more comfortable. They are now at ease. They are able to get their answers, and they know that hospitals being patient advocate and working with them.
Yes. I think that was one of her big reassurances, was that, and again, because of my own personal experience as a physician advisor, I could speak to this much more confidently than someone who does not work within this space. So it was a benefit that I could say, rest assured, we have a process in place. We know what to do. We will handle this. I can't tell you with 100% certainty, but I'm pretty sure that we will take care of this, and it's going to be fine. I think that was of great reassurance to this patient as she went through her hospitalization, because that's a definite dissatisfier for her care. That was an enormous amount of anxiety that was added to already a stressful situation. She was sick and bacteremic and in the hospital. And so I think that it was of great benefit that I personally could provide that reassurance as much as possible to her and her family. Even the case manager on the floor was relieved when I knew where to take the information. You can see the look on her face. So again, it's knowing where to take that information to. So it can be difficult and challenging when you have to talk about things that shouldn't be part of the discussion. The insurance and the payments and out of network and cost and things like that should not be a factor when you're sick. But unfortunately, they are. And so navigating that discussion with a patient and their family is not an easy one to do.
Glad that had a happy ending. So
it did, yes.
For sharing that case with us.
Yeah, absolutely.
The Association of Physician Leadership in Care Management, or APPLECOM, was created to provide support and education for physicians in this field. APPLECOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. AppleCom is inclusive of all practice settings. Membership in AppleCom also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, AppleCom membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers, join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acmaweb.org/membership to learn more.
I was thinking that was a very good case. Thanks for sharing, Ariana. I believe you have another case. Why don't we go ahead and...
Sure, we can certainly do that one as well. This one I have a little more vague details on because it was a little while ago, but we can get the gist of the discussion. The patient this time had straight Medicare, so not a Medicare Advantage plan, not any other commercial plan. I'm trying to remember what her presenting symptoms were, but a lot of vague symptoms. I think abdominal pain was one of them, but there were other issues as well. I don't remember if it was shortness of breath or something else, but it wasn't entirely related to her abdomen. But as an outpatient, she had been seeing an outside GI provider and had not been able to get in to see that provider and needed to be rescoped. I believe it was because of some esophageal stricture or, something along those lines, and had not been able to get in to see her provider, but was totally stable and she was improving from a clinical perspective. And then she developed, I believe she described it as, I'm falling apart. What her perception was that she was far more unstable than she actually was. And then we wanted to engage GI, but then we were approaching a weekend. And because the patient was totally stable and we were really approaching discharge, actually, there really wasn't anything acute that needed to be managed or treated while she was still in the hospital. So it certainly was within reason to discharge her, to send her back to her outside GI provider to go back and be seen. And the patient did not want to do that. And she wanted to stay in the hospital and have everything all worked up before she left the hospital. Well, one problem is that there was basically no medical necessity to keep her over that weekend awaiting whatever was going to be done by GI early the following week. So then that led to a discussion of, I have to talk to you about this, which is, this was not the original reason why you were admitted, and we don't have a lot of medical necessity other than this to keep you in the hospital. This then therefore begs the question of, will we get a denial from Medicare? Because this was not the original reason for your admission, nor was it something that needed to be done during this admission, and that it could be deferred to the outpatient setting. And would we, I realize that the chances of that are quite small, but would we receive a denial because this was an unrelated procedure that was going to take place while she was in the hospital? And having and navigating that discussion with her, when it kind of went to some of her reaction was, it never used to be like this. It never used to be this way, where money was the thing that everyone was thinking about, and things like that. And she got very emotional as part of those discussions. And so I thought I would just get both of your perspectives on, what do you do when you have to give them full disclosure that we could get a denial, that it might not be covered? It's an uncomfortable situation to be in, and you're trying to help them and tell them that it's going to be okay. But I'd like to hear your thoughts on how to navigate those kinds of situations.
Yeah, I think it's complicated. I do think, as a physician advisor, part of the scope of practice is being good stewards of our medical, resources, making sure there's medical necessity. Mm-hmm. I think the likelihood of a denial is probably low, but we can't just do things because Medicare is probably not going to deny it, because they just don't look at that level of detail.
That's correct.
We are supposed to be policing ourselves, making sure that we are delivering resources that are truly medically necessary, doing it at the right level of care. Shouldn't be are we going to get caught or not? Mm-hmm. So I think that's where I always go with this situation. What is the right thing to do? And oftentimes we have this conversation as a physician advisor with our frontline clinicians, because sometimes they're part of the problem. We're like, well, why don't I just get that follow-up MRI, or let's get that screening colonoscopy, or let's get whatever, and wrap up the patient with a nice bow. And there's something satisfying about that. But I don't know if your hospitals are like ours, but we're short on beds.
Correct.
We've got patients boarding in our emergency room. That is not a safe situation. We have other patients that are sicker, getting delayed if we've got other non-critical patients taking that procedural slot. Everything, it has a ripple ripple effect. So I think one, for all patients, always try to set the expectation that we are going to be focusing in on this problem. I usually, personally, when I'm a hospitalist, will say, we're going to be looking for this, this, and this. And if they bring up, oh, can I get, I'm like, no, we can't do that while you're here for another problem. So really setting expectations from the beginning, I think, is key to this. And you need your clinician helping you say the same message. Because I think if they're getting two different messages from you as a physician advisor and they're attending, it's going to be hard. So I'll pass the ball, hot potato on to you and see what you want to do in this one.
There is no answer to this. It's, this is certainly not an easy, it's not an easy discussion. So
I want to echo what Rebecca already said, which is in these case scenarios, again, we try making sure was the services that we provided medically necessary to be provided in hospital setting, or was it for patient convenience or comfort? Right. And if it's more of the later, like, hey, patient could have been discharged and done as an outpatient, but stayed to get it inpatient, not because of medical necessity at that time, then we would not be, again, I don't know how long the patient was in hospital for, was 2 midnight for...
She was.
Before this decision met or not. Oh, so it was met and the patient was inpatient by that time already?
Yes.
Okay. Okay, so we're not worried about, because technically those days would not be counting towards the 2 midnight rule because it was not a medically necessary midnight.
Yeah, that's correct. It's more like medical necessity on the back end as opposed to medical necessity on the front end. So yes, but that is a valid question for sure.
Because again, when we are we look at each midnight, it was that medically necessary in the first 2 midnights, especially before we make that determination of inpatient. So it sounds like there was care needed and now patient is still here. And like Rebecca said, we are also pretty full and have backup in the EDs. And it almost boils down to that point where patient is not comfortable going home. They have ability to appeal their discharge if medically they're ready and the team decides. But again, first things first, team has to agree, team has to make that decision. Is patient medically ready to be discharged? And second thing, I find it very helpful as a leader, as well as physician advisor, as well as hospitalist, I often say, let's go in together to talk the patient so that there is common understanding. When I say together, I mean the bedside nurses, the case manager, the social worker, the physician advisor, the hospitalist. We don't always have physician advisor go into these discussions, but commonly the care manager, social worker, nurses, and provider go in so that there is no staff splitting either. And because oftentimes we want to do the right thing for our patients, and we care for our patients, and that's a good thing, and we feel bad for them that they are hurting, and somebody will be like, oh, can we try getting this done, because we want to try doing the right thing for the patient, which is understandably, we care, we want to do it, but at the same time, are we risking another patient's ability to get that access and care who needs it more urgently than this patient? So things to keep in mind.
Yeah, I think both of you have brought up excellent points, and also about the potential for intervention, especially an on-site physician advisor, because had I not, again, this is the similar theme to the first patient, which is, I mean, I know a little more about this part of our world, but had I not been one of the physician advisors, I don't know that I would have felt as comfortable, not that it was a comfortable discussion to begin with, because it wasn't, but I would have felt even less comfortable having that discussion without having care management in the room with me to discuss what the potentials were about how you're no longer meeting medical necessity, and you're not going to use those exact words with the patient, but you get the message of how do you deliver that message to the patient when you don't have the knowledge of the lingo, the language, and the behind the scenes knowledge that we have as physician advisors. It almost can put you in a little more of an uncomfortable position because you know more. So therefore, you're taking more of the brunt of the challenge of the discussion than even, say, a provider who is not a physician advisor or who doesn't have that knowledge. They're going to lean more on care management and let care management shoulder that difficult part of that discussion. So it just made for it was a bit of an emotionally charged discussion with her because of that. And ultimately she decided to stay, and that was her decision. And as long as she made an informed decision of this could happen and that there could potentially be an inpatient denial for the latter part of her stay, it's the likelihood, again, extremely low, but still possible. And so as long as she had that understanding, then she made an informed decision, and that was that. But it did make for some challenging few minutes. It wasn't an easy discussion.
I do think this larger topic is something that I think you can try to take a more proactive approach to. Like, we try to incorporate that into our education. Our physician advisors, we work with our residents, we care progression, hammering home that you really need to think about the medical necessity. Mm-hmm. Why are you doing that test? Why are you doing this during this day? Is it going to change what you do? Mm-hmm. And really just trying to create the medical decision making that's really about appropriate utilization of medical resources, especially in the inpatient space.
Correct.
And we also try to have that same conversation with our hospitalists. And sometimes it's focusing in on certain tests that you really should think about doing in the outpatient setting. And we even have our nurses kind of focusing in on that too, or our care managers, part of our multidisciplinary rounds, really looking for those opportunities to say, hey, wait a minute, time out. Does that really need to be done during this stay? Because it can eat up a day or two for length of stay. So I think it can be one of those hard culture change things to do, but I think it's probably one of those things that's worthwhile to take on. It's kind of the long game, if you will, with but yeah, another great case.
And I think that's where another significance of physician advisor comes in, is sharing that wealth of knowledge with the bedside providers, having that education beforehand. Hey, if patient does not feel comfortable with discharge, but patient's medically ready, it's okay to discharge, and let the case manager provide them with the HIN notice. They have ability to appeal. Don't be nervous about it. Yes, they have right to appeal. They can appeal their discharge. And a lot of times when I'm taking care of such patients, and patients like, no, and I'm like, that's totally fine. I am still discharging you. You have right to appeal. Just let us know, or go ahead and appeal the discharge.
Right.
And a lot of times, because sometimes I've run into where they'll be like, oh, we'll run into weekend, and by the time we'll get response, that itself is Monday. I'm like, not necessarily. We have been pretty fortunate to get the responses from our reviewers within 24 hours, even on weekends. And then I just let the patients know as well. You can go ahead and appeal your discharge. Once appealed and we get a decision, if the decision is agreement for discharge, you have 24 hours to leave, or you will be billed. And a lot of times, after having the discussion and saying, I care about the patient, I'm not trying to push them out. They have the ability, they have the right. And sometimes patient would be like, would you be mad at me if I do appeal the discharge? I'm like, no, I would not be upset. I would not be mad. You have the right. I want to make sure you know everything. And then go ahead. Sometimes they would appeal the discharge. Sometimes they would not. Just that, okay, they have an understanding and they ask. And once the decision's made, but I have to remind the providers that you have to put in a discharge order. Then only the whole appeal process starts. And it can still take 24 to 48 hours. So that's additional time that patient has to get more comfortable.
Yeah, I think that's also a valid point too, which is, again, when your hospitalist may not necessarily feel as comfortable with some of these discussions or this decision making, they look for guidance from their subject matter experts. And that's where I think physician advisors can, at least partially, if not totally, depending on the circumstance, fill that gap, especially for on-site. It makes a case for an on-site colleague that can assist with these kinds of situations if necessary. Because I know that a lot of my partners anyway, as hospitalists, they would look to care management and bring care management in the room with them. And sometimes the case managers don't necessarily feel as comfortable doing it either, right? And so sometimes they will loop in the physician advisors for that backup as well, and that level of expertise. So that makes a case for, I know, does this happen all that often? Thankfully, no, but it does happen, and it happens with enough regularity that having some kind of a break the glass in case of emergency kind of thing. Who do you call if you need that assistance? Where do you go to get the help that you might require?
Yeah, thanks for sharing these great cases. A lot of learning opportunity here.
Yeah, absolutely.
Thank you to everyone for joining us for another episode of Case by Case. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so that you are notified when we upload new episodes. Until next time, this was Care Transitions Today, Case by Case.